Now we're going to talk about spinal cord injuries. And there's different mechanisms, reasons, and how patients get a spinal cord injury. They can have a hyperextension or a hyperflexion of the spinal cord. They can have compression fractures, which you might see with some of your little old ladies with osteoporosis, where the vertebrae just kind of crumble and compress on the spinal cord. Or they can have penetrating injuries, either gunshots or stab wounds or other types of injuries that actually cut and slice through the spinal cord. Depending on the location and the level of the injury, patients are going to have different signs and symptoms. So because the anterior cord is where the motor spinal nerves exit, if patients have damage just to the anterior cord, they're going to have a loss of motor function, but they're going to have intact sensation. If they have a posterior cord injury, the opposite is going to happen, because the posterior cord is where the sensory nerves exit. So patients are going to lose touch, vibration, sensation, but they're going to have motor function intact. But think of how hard it would be to ambulate, even if you have intact motor function, if you have no sensation. You know, so much a part of walking involves us feeling where our feet are as we're going down the sidewalk. So these patients have have mobility issues just by virtue of the fact that they have damage to the sensory nerves. Brown-Séquard injuries. This is where only one side of the spinal cord is damaged, but it involves both the anterior and posterior part of that one side, so either a left or right side of the spinal cord. And so what patients will have is what's called ipsilateral loss of pain and of sensation and motor function. Ipsilateral meaning one-sided. Patients can have central cord injuries. Usually those come because of compressions and for other types of fractures, and usually it's in the cervical area. And what patients will have is a loss of upper extremity motor function, or a decrease in upper extremity motor function greater than their lower extremity issues. And so we just deal with issues of severity. Patients can have damage, bruising of the spinal cord, or complete transection and disconnection of the communication. So whatever is happening is wherever that level of injury is everything distal to that level of injury is going to be affecting their neurological status. So our case study that we're going to talk about is Zach Wright, who's 20 and dove into shallow water, suffered a C-spine injury, was pulled out of the pond and resuscitated. You're the nurse in the emergency room, and this is the paramedic field report. You have no movement or sensation below the clavicles. His Glasgow coma score is 10. He is intubated, and he is getting 100% oxygen via ambu bag. He is alert and anxious and grimacing with pain. Pupils are equal and reactive. The skin below the injury is cool to the touch. Blood pressure 90/60, pulse 45. He's being ventilated at 27 per minute. And remember what Pat said about that whole, we're getting all overexcited with our ventilations with the ambu bag, and we're actually overventilating patients. So in this particular scenario, case study, there might be some overventilation issues going on. He's got an IV of lactated ringers going at 100 an hour through the antecubital. So with any kind of trauma, and we're going to talk a lot more about this when we get into bioterrorism and emergency and trauma nursing, we look at the acronym ABCDE. Now you're familiar with ABC, airway, breathing, circulation. The D stands for disability, and the E stands for exposure. And we'll talk about each one of those items. But based on his assessment, based on what's going on with him, how are we going to address, either assess and intervene for airway issues? What kinds of things are we going to do and be assessing? So he's going to be, we're going to have a vent ready. So we have to intubate him, and we have to breathe for him. What assessments do you think we need to do to evaluate how well his airway is functioning? What's that? Capnography. So assessing his O2 sats, his ABGs, his whether or not he is intubated in the proper area. Are both lungs being ventilated? That sort of thing. Suctioning may be very important. I mean, he just got pulled from a lake. Near drowning incident, so he may have pond water in his lungs. He's going to have secretions as a result of being intubated. So suctioning and making sure that the airway is kept open. Inserting an NG tube is something that you'll probably have to do to suction out any of the stomach contents that could potentially come up and cause aspiration. So that's our airway. What are we going to do and assess as it relates to breathing? What's that? Right, so we're going to be again breathing for him to make sure that we have equal lung expansion. Slow his respirations down because we don't want to hyperventilate him. We don't want to increase the intrathoracic pressure, because what happens when we increase intrathoracic pressure? Decreases venous return. We've got decreased cardiac output. And we're already dealing with a blood pressure of 90/60 and a heart rate of 45. So his cardiac output kind of stinks already. Circulation. What are we going to do to assess and maintain circulation? Doppler. So we're going to be assessing pulses. Put him on an EKG. To fluids and electrolytes to make sure that we have good balance. We want to evaluate his urinary output, because that's going to give us a good indication of things like kidney function and fluid balance. The D stands for disability. This is where we do in what is called primary survey, and we'll talk about that more in emergency, where we do a quick neurological assessment. We already know he's got a C-spine injury, he's got the collar on, but we want to assess and see if he has a head injury, because we know he got the C-spine from diving into the shallow water. Maybe he's got a head injury as well. So we're going to do a quick head-to-toe neurological assessment, not a big, thorough, time-consuming one, but just identify any other issues, neurological issues that might be happening. That's our disability. And then exposure is where we cut off the clothes and expose the body to make sure that there are no other life-threatening injuries and issues that we have to deal with. So A, B, C, D, and E, airway, breathing, circulation. Disability is a quick neuro assessment, and exposure is assessing for any other life-threatening injuries. Yes, because that would be doing your Glasgow Coma Scale and assessing again whether or not there's signs of any increased intracranial pressure, and pupil reaction would be a good indication of that. But, you know, we're not going to test each one of the cranial nerves individually. You know, we'll do a quick, you know, can you move your hands? Can you, you know, and of course he has no motion or feeling below the level of the clavicles. And then our ongoing assessment is going to be maintaining and evaluating all of those issues and making sure that he does not deviate from baseline. So again, our baseline assessment, very, very important. We need to log roll him to assess for any other injuries, because we don't want to twist that spine and cause any further damages. We're going to determine if he needs to go to surgery, or if he's even able to go to surgery given the extent of his injuries. So what do these vital signs indicate? Blood pressure of 90/60 and a pulse of 45. What? Neurogenic shock or spinal shock. Spinal shock can happen in patients that have had severe spinal cord injuries, where they have the hypotension and the bradycardia. That reminds you very much of neurogenic shock that we talked about last week. But also what they will have is flaccid paralysis below the level of the injury. So unlike that patient with increased intracranial pressure who is posturing, abnormal flexion and abnormal extension where they're stiffened, this patient is totally flaccid. The extremities are flaccid. And there's a loss of reflex activity. All of this below the level of that injury. And this can take weeks or months to resolve, depending on the severity of the spinal cord injury. So what we're going to do is we're going to give him atropine to bring his heart rate up, and vasopressors to try to bring his blood pressure up. Because what we have here is damage to the autonomic nervous system. And what did we say was the problem with neurogenic shock? What did we lose? Sympathetic tone. The ability of the body to tell those peripheral blood vessels to constrict and raise the blood pressure. The inability of the brain to tell the heart to start pumping more rapidly, to do that compensatory mechanism, the fight or flight. So this is what's going to happen with the patient with a spinal cord injury, and this can last for quite a while. Patients will have problems maintaining their blood pressure. And depending on how well they heal after this, how long it takes, they may always have issues maintaining their blood pressure when you change positions, when you raise the head of the bed. They will also have a loss of temperature, so they'll become cold and clammy below the level of the injury in spinal shock. They lose peristalsis, because again, there's nothing telling the bowels what to do. They lose bladder control because there's nothing telling the bladder what to do. It's not getting from the brain down to the extremities. Neurogenic bladder, yeah, because you've got a patient, we'll say when we talk about MS, because the nerves that are telling the bladder when to contract and release urine and all that have been damaged because of the MS. In this case, there's no communication. So yeah, technically it's a neurogenic bladder, but he's lost all function below the level of the injury. Yes? It can be either. Usually it's urinary retention that we have issues with, and bowel, is a sluggish bowel and impaction of the bowels. And we'll talk about that as a complication a little bit later. So labs, what are we going to be doing for labs on this patient? ABGs, H&H, so a CBC, so it's going to tell us bleeding, it's going to tell us his H&H, clotting times we're going to do, so the PT and the PTT. How about x-rays and scans? What do we need to do for him? Yeah, everything. Yeah, a complete body MRI or a CAT scan so we can tell what's going on and what other injuries might be happening. C-spine films to assess the stability or instability of the fracture that we know he has. Chest x-rays to assess for fluid in the lungs from that near drowning issue, and maybe even ARDS as a result of that. And then we have to administer some medications. So why would we give solumedrol methylprednisolone to a patient with a spinal cord injury? To reduce inflammation. And this is really important with spinal cord injuries. If they get solumedrol within 6 to 8 hours of the injury, it significantly reduces the swelling of the spinal cord and helps to reduce the neurological deficits that they might be experiencing long term. So the sooner we get that solumedrol into them, and that can be done either intravenously or directly into into the CSF through a spinal tap. Because when you think about it, you've got your injury here, and anytime you got an injury, there's going to be swelling. Well, it's not just going to be swelling below the level of the injury, there's going to be swelling above the level. So if we can reduce that swelling, that's going to reduce some of the deficits that he might be experiencing or could possibly permanently experience above the actual level of the injury by doing that solumedrol, reducing the inflammation. So very high doses of solumedrol will be given to that patient in those immediate hours after their spinal cord injury. Dextran, we talked about a little bit about Dextran as a volume expander, a plasma expander when we talked about shock. We'll be giving this to improve blood flow to the spinal cord. We talked about atropine or dopamine, atropine to raise that bradycardia, dopamine to give him a better blood pressure because he can't vasoconstrict on his own. Why pain meds and anti-anxiety meds? To decrease oxygen demands. If he's agitated, if he's in pain, if he's anxious, then more of his energy is going towards that than towards healing his injury. Dantrolene, baclofen, those are antispasmodics. Baclofen is one that you'll see very frequently with MS patients. Because many patients, even if they have no sensation or movement below the level of the injury, can have muscle spasms, which can be very uncomfortable for that patient. And peptic ulcer prophylaxis, Pepsid, proton pump inhibitors, things that are going to prevent him from having GERD because he's going to be on a vent. We don't want him to aspirate and get VAP. So he goes to the ICU. He spends 2 hours. Oh, first of all, I keep forgetting. I had to write on here that I got these slides. This is a way, something that we could use for Zach. It's called cervical skull traction. They put a bolt into the skull and hang a weight off of those tongs, and that keeps the C-spine in alignment for those patients with either post-fusion surgery or if they have very unstable C-spine fractures as they heal. They could be put in a striker bed. Those patients who are severely unstable, where even Logrolling is going to be contraindicated because it can cause further spinal cord damage. They will lay, in this particular picture, the patient's head is facing downward towards the floor, and every 2 hours we got to change position because we don't want skin breakdown. So that top stretcher kind of goes down over him, we flip him upside down, and now he's looking up at the ceiling. So think how scary that's got to be. You're on sedation, you've got possibly a head injury, confusion, anxiety, and now they're flipping you upside down every 2 hours. Some of them will go side to side. But I was reading a book a long time ago by a girl that had a similar situation. She dove into shallow water and said that that was the most frightening part of her hospitalization before she had her fusion surgery and was able to, get up in a wheelchair and go home, was that change in position. It was absolutely terrifying to her. He may need, even sometimes permanently, a halo brace. Again, where it's bolted into their skull and then it rests on their shoulders so that it keeps them from moving their neck in any kind of position. So pin care, because we've got a nice little avenue for an osteomyelitis if we don't prevent infection. So now he spent 2 weeks in ICU. He comes out on your rehab floor, and he is now has a trach with spontaneous diaphragmatic breathing. He has continuous tube feeds at 60 an hour. He has movement in the upper arms and feeling to the nipple line, so that's improved from that original paramedic report. He has a halo device. His blood pressure drops when the head of the bed is raised, so he's still having vasopressor issues. So what orders do you anticipate, because he's got a trach with diaphragmatic breathing? Suctioning, but how about weaning? Think he might be a candidate for seeing if he can wean off that ventilator? And because we're weaning him off the ventilator, what are we going to have for orders with the tube feedings? Are we going to advance to a regular diet? I think that'd be a good idea, because if he's off the vent, then he can start eating. We have to worry about aspiration. He's going to have PT and OT because now he's got some movement. We can work on some upper arm and to use the upper arm muscles in order to move his arm and enable him to, be able to control his bed settings, to when he gets up in a wheelchair at some point, to be able to move that wheelchair around by himself. The halo device, we're going to do the pin care. And we've been giving him vasopressors because of the blood pressure. But we don't want him to be on vasopressors for the rest of his life, right? So what kinds of things can we do to help improve venous return that are less invasive than giving him like dopamine? Compression stockings, abdominal binders. And some patients with spinal cord injuries will wear an abdominal binder for the rest of their life because they cannot maintain an adequate blood pressure if you sit them up without having these devices to push the blood, because the blood just kind of goes right to the extremities when you sit them up, and they lose their blood pressure. Right, and that's part of what physical therapy is going to do, and occupational therapy is very gradually raise the head of the bed to the point where he can tolerate and compensate on his own. So within a week, he has PT and OT twice a day. He has a bowel program every other day, very important with spinal cord injury patients. So suppositories, enemas, and worst case scenario, disimpaction. Even though Jan made you raise your right hand and promise in Jerry lecture you never, ever, ever disimpact, with these patients you may have to. He's tolerating the head of the bed at 45, so that's great. Tolerating a soft diet, and his pain is controlled, and he's kind of moving along as positively as a 20-year-old that is now permanently paralyzed can possibly be. But now he suddenly rings the call bell. He's having a headache, nasal stuffiness, he's flushed, skin is cold below the level of the injury with goosebumps. So what is this called? Autonomic dysreflexia. It is a severe, exaggerated autonomic nervous system response that happens in high-level spinal cord injury patients. Autonomic dysreflexia, DYS reflexia. And the causes, the primary causes of this in most spinal cord injury patients are a distended bladder, an impacted rectum, or tight clothing. So the first thing you're going to do in a patient who's exhibiting these signs and symptoms, they also have a massive increase in their blood pressure with this response. So you're going to put the head of the bed up, because now you don't care if he drops his blood pressure. You want him to drop his blood pressure. So sit up the head of the bed, and then you have to investigate what is our problem. So if he has a Foley catheter, you need to check and make sure it's still draining. And if there's a kink, straighten out the kink. If it needs to be irrigated, irrigate it. If he's on intermittent caths, then you need to check for bladder distension. And if he is distended, you need to straight cath him right away. But if that's not the problem, the next thing you're going to check is his rectum to see if he has stool impacted in the rectum. And if he does, you are going to disimpact right away. Because correcting the problem is going to get him out of this syndrome. If we don't correct the problem, his blood pressure is going to get higher and higher and higher, and he could stroke out. So raise the head of the bed, find out what the problem is, and again, usually it's either a distended bladder or an impacted rectum, and correct the situation right away. So a lot of teaching when you send Zach home, because his family and he need to be aware that he needs to keep that bowel program going. Come hell or high water, keep those bowels active. Don't get impacted. Make sure that in times of the year, maybe when it's hot out and you're drinking a lot more fluids and you're on an intermittent cath scenario, then maybe you need to check and straight cath more frequently if you're drinking more fluids or you're diuresing a little bit more than usual. And again, this happens primarily in patients with high-level thoracic or higher spinal cord injuries. Looking at the clock saying, okay, what time is it really? Okay, before we go on to seizures and epilepsy, any questions about spinal cord injury? Yes?
I know that usually men, when they have spinal cord injuries, they ask about statusepilepticus.
Mm-hmm.
So I have a question about the men who have the intact motor and loss of sensation.
Mm-hmm.
When they have sex, are they able to have music?
If they have intact sensation, probably. They have no sensation.
Motor but loss of sensation.
Okay, then they won't feel it. No.
Because I know when men are in wheelchairs, they're able to have
Right.
sex,
But a lot will depend on the extent of their injury. So they may be able to get an erection, but not feel it.
The ones that have the loss, the ones that have the intact sensation but loss of motor will be able to feel it.
But they won't. Yeah, but then they probably can't achieve erection because they don't have the motor function. Motor and so yeah, it's. Oh yeah, and they will, because it is a very. And I'm going to pause. I'm going to talk about seizures and epilepsy. What is the difference between a seizure and when does it become epilepsy? Okay, so a seizure is usually an isolated or some kind of uncontrolled, abnormal firing of the neurons. And usually it's because of an underlying problem, like in a baby with a fever gets a seizure. They don't have epilepsy, they're getting a seizure. A patient in alcohol withdrawal has a seizure because of that withdrawal syndrome. Metabolic imbalances can cause seizures. So usually with a seizure, if you can control or eliminate that underlying cause, they're going to stop having seizures. When it becomes epilepsy, is when that patient has continuous, chronic, unprovoked seizures that don't have an underlying cause outside of the central nervous system. Usually if the patient has epilepsy, there's either a problem with the actual neurons firing abnormally or problems with imbalanced neurotransmitters causing the neurons to fire inappropriately. It can be. There's a lot of different reasons why people get seizures. They can have them, again, they can develop a seizure disorder because of a traumatic brain injury. But that's not what you would classify as epilepsy, which is we really don't know oftentimes why that patient is having these chronic seizures. It's just something's going on in the brain that's, you know, where the neurons are malfunctioning. So what we have in when we talk about seizures is there's two different kinds. There are partial seizures, and those partial seizures are called partial because they're located in only one area of the brain, usually one side of the one hemisphere. You can hear partial seizures referred to as focal or local seizures. And they're classified as simple or complex. Simple seizures, simple partial seizures, patients are usually conscious throughout the seizure and oftentimes have an aura prior to the seizure. Now the aura can be an odd smell, a blurred vision, numbness and tingling, weird lights in the periphery, similar to the kinds of auras that many people get prior to having migraines. Complex seizures, patients do lose consciousness, whereas the simple they don't. So these are partial seizures. They're located in one hemisphere of the brain. Generalized seizures happen because of abnormal activity in various parts of the brain, many different parts of the brain. And there's 6 types of generalized seizures. And there's a box on 46-1 that talks about all the different types of seizures. Tonic-clonic is kind of what you think of the classic grand mal seizure, which is not the politically correct term to use any longer. So tonic-clonic seizures are the big seizures you see if somebody has a seizure on a television show or a movie. That's usually the kind of seizure that they're having. They lose consciousness. They're usually incontinent. They have stiffening and rigidity of the muscles and jerking of the extremities. So the tonic is that stiffening and rigidity of the muscles, and the clonic is the jerking of the extremities. If they can have just tonic, so where they have just increased muscle tone and stiffening. They can have just clonic, where they're just having the spasming and the contracting and relaxing and movement of the extremities. They can have an absence seizure, what used to be called the petit mal seizure. And that's where the patient has a very brief level of loss of consciousness, and then they come right back to baseline. So that could be, you know, your kid sitting there gazing out the window and not paying attention in class could actually be having an absence seizure. Yes?
The clonic seizure, is that always a bilateral?
Not necessarily.
So how is that different from myoclonic?
The myoclonic is a briefer in terms of rigidity and because the myoclonic is like, yeah, it's like the clonic, jerking and stiffening of the recess, but it's very brief. The atonic is where they have a total loss of muscle tone and they just drop. So, you know, you get a patient that comes into the emergency room, you know, I don't know what happened, I fell. Now, they're going to do a cardiac workup to see if it was a syncopal episode because of bradycardia, and they're going to do a neurological workup to see if they had an atonic seizure to figure out why this person just suddenly, you know, ended up on the floor. Now, status epilepticus happens when there's the seizure lasts longer than 5 minutes. Now, when you think about that, has anybody ever witnessed somebody having a seizure? Did it seem like it lasted for an eternity? But probably it lasted for a minute or less. But when you're the one watching somebody have a seizure, it seems like it's going on forever. So a status epilepticus is when the seizure lasts for longer than 5 minutes, or the patient has repeated seizures within a 30-minute period. And this is a neurological emergency because they cannot, their brain cannot tolerate, and their body cannot tolerate those repetitive seizures. So this can happen with sudden withdrawal of their antiepileptic drugs. So they should never just stop taking them. Infections, alcohol withdrawal. Has anybody used the CWA scale in patients that, yeah. So basically what you're doing is you're trying to detect that patient before they go into the DTs, before they go into status epilepticus, by giving them benzos, usually Valium or atropine. Atropine, all right. Ativan, not atropine, Ativan, to keep them calm and not go into status epilepticus. Metabolic imbalances can cause this as well, because remember when we talked about neurotransmitters, alkalosis can excite those neurotransmitters and cause seizures. So the non-surgical treatment is going to be, maintaining an airway. Hopefully we've got IV access. If not, we're going to have to put them under general anesthesia to get IV access, and then administer Valium, Ativan, Versed, antiepileptic drugs, and get them out of this syndrome, or you can cause some permanent damage, permanent neurological damage. Now, ATI and your book have a lot of different antiepileptic drugs, and there's new ones coming out all the time, because a lot of patients will respond to one drug for a while, and then it doesn't work anymore, and they have to try them out on something new, or they can't tolerate the side effects. I picked these three to kind of focus on for our exam, mainly because that seems to be common medications that come up on NCLEX questions. But again, this is by no means an extensive list. But I picked these because they have toxicity issues, they have other types of issues, interactions that are going to be commonly come up on an NCLEX question. And I picked Tegretol and Depakote because they're also given to psychiatric patients. So they're not always just used for seizure disorders, they're also used for psychiatric disorders. So let's take Dilantin, Phenytoin first. What is the therapeutic level? Where do we want to see that patient? 10 to 20. 10 to 20 micrograms per milliliter. Now the usual dose for an adult is anywhere from 100 milligrams 3 times a day up to 600 milligrams per day. And that will again change with some patients, and some patients may have considerably more than that, some less. Per day. So the precautions that we have to take with Dilantin, number one is its interaction with Coumadin. Coumadin inhibits the metabolism of Dilantin, which can make that patient go into a toxic level. So if your patient who is on Dilantin and they're well controlled for their seizures needs to have an anticoagulant because of maybe a new diagnosis of AFib, then you're going to have their levels drawn more frequently to make sure that, and their dose of Dilantin is going to have to be lowered so that they don't become toxic. The other thing is if you're giving Dilantin IV, it can only be mixed in normal saline, and it has to be administered very slowly, otherwise it can cause dysrhythmias. Okay, Tegretol, carbamazepine, used for psychiatric, as a psychiatric drug as well as an antiepileptic. What's the therapeutic range for that? 4 to 12. 4 to 12 micrograms per milliliter. An adult can get up to 1,600 milligrams per day in divided doses. Up to 1,600 milligrams. And you're going to be monitoring this patient not only for their Tegretol levels, but also their CBC, because they are at risk for aplastic anemia or agranulocytosis. Agranulocytosis. or aplastic anemia. So they're going to have not only their Tegretol levels drawn on a regular basis, but also CBCs on a regular basis. Depakote, valproic acid, has a therapeutic level of, you said it for the first one, 50 to 100 micrograms per milliliter. The maximum dose on Depakote is 60 milligrams per kilogram per day. 60 milligrams per kilogram per day. This is all stuff you guys could have looked up in your drug books like I asked you to. And you need to monitor liver functions as well as their Depakote levels, because these can cause liver failure. So those are kind of the big three that you might see on NCLEX questions, but there's a lot of anti-epileptic drugs out there, which you'll see when you've done your ATI and also in the book. So while we are dealing with that patient, we have certain precautions that we follow both before the patient has a seizure, during the seizure, and then in the post-ictal phase, that after the seizure. So before the seizure, we know that patient is a known epileptic or seizure disorder. What kinds of things do we need in the room? Padded side rails, if it's allowed by your facility. Suction, because patients can have secretions, they can vomit. You need to be able to suction in the post-ictal phase so they don't aspirate. An oral airway. We are not going to put the oral airway in during the seizure, but after the seizure is over, if we're having trouble suctioning and getting an airway, we may have to put in that oral airway. So always have one of those. But we are not going to have a tongue blade or anything else to put in the patient's mouth while they're having the seizure. So if you've seen that in the movies, that's not what we do. Very dangerous for the patient because they can break teeth and damage their jaw. Also very dangerous for you if your fingers happen to get in while you're trying to insert the wooden spoon or tongue blade or whatever you're using. During the seizure, you need to document, number one, what time it started, what the patient said or did prior to the onset of the seizure, because sometimes they can complain of an aura or they can cry out. And then just make sure that they are in a safe position, put them in the rescue position on their side so that if they do vomit or they have a lot of secretions, they won't aspirate. You're never going to try to restrain them, try to do vital signs or anything during the actual seizure. Just watch, document what's going on. Then in the post-ictal phase, then you're going to do your vital signs, you're going to suction, you're going to maintain your airway. The patient may be very fatigued, may have trouble waking up, just let them wake up. If they have oxygen on, then you would leave it on, but you're not going to try to put oxygen on them during the seizure. Because you could hurt yourself, you could hurt the patient. So basically just put them in that rescue position, because really once the seizure is over, then you're going to know what airway issues you have, whether or not they need oxygen, suctioning, and that sort of thing. Just let them wake up on their own. Once the seizure itself stops, then you can start doing vital signs. You can put oxygen on them. If you have IV access and there's a medication ordered, you can give that at the time. But you don't want to do anything that could potentially restrain them, their extremities while they're actively seizing. And then just let them wake up.
Would you give Ativan while they're active?
Only in the case of status epilepticus, where you've got to do something to get them out of that seizure. But normally you're going to just wait until the seizure is over and then give whatever medications. Patients after if they have recurrent seizures that are not being controlled well with their anti-epileptic drugs can have surgery. They can have that awake craniotomy that we saw for the brain tumor, where they can map the areas of the brain to see if they can figure out where the seizures are coming from. They can stimulate the areas of the brain, and if a seizure happens, then they know that they can maybe just remove that part of the brain tissue that's causing the seizures. They've done surgeries where they've cut the connections between the two hemispheres of the brain, so that can sometimes control seizures. Patients can have a device implanted called a vagal nerve stimulator that they can activate when they sense an aura to stop the seizure from happening. So you may see a patient with a chronic seizure disorder, with epilepsy, whose antiepileptic drugs are they're relatively in control, but occasionally they may it may kind of overflow their control, and then if they start having the signs and symptoms of an impending seizure, they can activate the vagal nerve stimulator, and usually that will stop the seizure activity. Yes. It could possibly be the Depakote because of the liver failure. Because if you have liver failure, you're going to. It's possibly that one, but again, there's so many meds out there, and they've got a lot of side effects. Some patients do well on one medication and have a lot of side effects with a different one. So it's very random as to how how the patient is going to be controlled. Yeah. Yeah. So Depakote, yeah, because it does affect the liver. Okay, so let's do the math. We have Phenytoin Dilantin, 200 milligrams IV push, ordered for your patient with status epilepticus. You have 100 milligrams in 2 mLs, not to exceed 50 milligrams per minute. How much will you draw for injection? How many minutes will it take to administer the dose? And how many milliliters per minute will you give? So desired over half times volume. What's your desired? 200 milligrams. What do you have? 100 in 2 mLs. So how many milliliters are you going to draw? 4 mLs. Now, how many minutes is it going to take for you to administer the dose? 4 minutes, because each ml is going to have how many milligrams in it? 50. And it says you cannot exceed 50 milligrams per minute. So you're going to give 4 milliliters you're going to give the dose over 4 minutes, so you're going to give 1 milliliter per minute. Is this working? Yes, it is. Okay, when you admit the patient with acute confusion, the nurse will interview the client about health problems and health history, primarily to determine the motivation for self-care, to include the patient in healthcare decisions, to use the information given by the patient to guide care, to assess the patient's baseline cognitive abilities. Noisy next door. You guys got to remember to grab a clicker when you come in. Are we going to work? Are we going to go? Good. Okay, so all of you said assess the patient's baseline cognitive ability. Why do we not use it for including the patient in healthcare decisions or use that information to guide care? Because they have acute confusion. So your keywords are the acute confusion. Patient didn't have confusion. Well, yeah, part of the reason that you're going to do that history is to include the patient and to get use their information. But you don't know how accurate their information is. But that's going to give you that baseline cognitive ability. To assess the functioning of the optic nerve, cranial nerve 2, the nurse should apply a cotton wisp strand to the cornea, have the patient read a magazine, shine a bright light into the pupil, check for equal opening of the eyelids. Okay, 19% said have the patient read a magazine, 71% said check the pupils, 10% said check for equal opening of the eyelids. So let's talk about our cranial nerves. What does the optic nerve tell you? Visual acuity, right? It's a sensory nerve. So, shining the bright light into the patient's pupil, which cranial nerve are we checking for that? The oculomotor. Equal opening of the eyelids. Oculomotor as well, right? So, Have the patient read a magazine. That's going to tell you their visual acuity. Seems silly, but that's one way of testing whether or not the patient can see, checking their visual acuity. Okay, the following orders are received for the patient who is unconscious after a head injury. Which one should you question? Perform neurochecks Q15 minutes, prepare for lumbar puncture, obtain x-rays of the skull and spine, do a computerized tomography scan with and without contrast. Which will you question? Okay, 20% questioned the neuro checks every 15 minutes, 45% questioned the lumbar, and 35% questioned the CAT scan. Why would you not be doing neuro checks every 15 minutes? Yeah, you're still going to be checking reflexes, whether or not they respond to pain, all that other stuff. So, yeah, neuro checks every 15 minutes is going to be part of your orders. Why would we not do a CAT scan? If we have a suspected head injury, we do need a CAT scan. So you're not going to question the CAT scan. You're not going to question the neuro checks. You're not going to question the x-rays. Why would you question the lumbar puncture? Because we don't know if he has increased intracranial pressure. So they're going to have to do a CAT scan first before they do the lumbar puncture on this patient. So that patient who is at risk for increased ICP, you're not going to just willy-nilly do a lumbar puncture without validating whether or not they have increased ICP. The patient is scheduled for a lumbar puncture. The nurse will plan to administer a sedative 30 minutes before, transfer the patient to radiology just before, place the patient on NPO status for 4 hours before, or help the patient lie on the side in the fetal position. Okay, 6% wanted to give a sedative, 35% said NPO, and 59% said lie in the fetal position. Do they need to be NPO for a lumbar puncture? No. They don't need a sedative and they don't need to go to radiology, but they do need to be in the fetal position. Or in the case of the pregnant woman who is going in for an epidural and can't get into a fetal position, then they're going to be, leaning over the bedside table in order to get their lumbar puncture for their epidural. Okay, after the nurse has taught the patient about Dilantin, which patient statement indicates understanding of the medication? I should use soft swabs rather than a toothbrush to clean my mouth. After I have a seizure, I should call an ambulance to take me to the hospital. I may need to have my blood taken frequently to check the level of the Dilantin. I will take the medication at the beginning of the seizure when I experience an aura. And 95% picked having the blood pressure, the blood levels checked. They should not be, they may have some gingivitis with Dilantin, but they should be using a toothbrush, a soft bristle toothbrush, because they need to make sure they don't get any infections. When a patient experiences a generalized tonic-clonic seizure in the ED, all of the following orders are received. Which one will the ED nurse implement first? Send to radiology for CAT scan, administer Valium, check capillary blood glucose, monitor level of consciousness. What's that? What, the polling?
No, the seizure.
Oh, the seizure. Oh. It still doesn't matter. Doesn't matter. No, that wasn't. 21% said give Valium, 8% said check glucose, and 71% said monitor level of consciousness. Okay, we have a patient that had a generalized tonic-clonic seizure. What is our first priority? Safety. Prevent another seizure by giving Valium or some other sedative medication. I don't care about their glucose, and I really don't care about their level of consciousness at this point. Are they? That yes, it can. But in this case, we got to do something first. We need to do something to prevent the seizure. Yes, Linda.
I was just thinking, because you said you don't give them anything when they're having the actual seizure. You said
But
it says experiences.
yep.
I don't think they're saying that it actually happened when they're saying overall.
Right, and it's and I did say that if you have IV access, you may be able to give the medication during the seizure if it doesn't require in any way restraining that patient. But you know, it doesn't say you are the ED nurse. You've got a patient that's had a seizure. Maybe I should change that to experienced. Then that would remove the ambiguity. So calm down. It's not an exam question. So you need to chill. Go in here. Okay, when preparing to admit the patient who's being treated for status epilepticus in the emergency department, so now you are the nurse on the med-surg floor, you're getting that patient who was treated for status epilepticus, now they're coming up to your unit. So they're not actively seizing. What do you need to have in the room? So suction tubing? Yes. Oxygen? Yes. NG tube? Why an NG tube? No, you don't need an NG tube. You're going to suction if they vomit, but you don't need an NG tube. You're not going to put down an NG tube when they have a seizure. Side rail pads? Yes. What's that? Yeah, the kid that had the spinal cord injury that you had a near drowning experience, we're not talking about that. We're talking about an epileptic patient, a patient who's had a seizure. You're not going to be putting down an NG, you're not going to need an NG tube for that patient. Side rail pads? Yes. Tongue blade? No. Oral airway? Yes. Okay, let me just stop this.